Good afternoon, everyone. My name is Carlton Allen. I am the Program Manager for Prevention at the Cancer and Prevention Research Institute of Texas. I have the honor and privilege of moderating this first section outlining the Texas-based colorectal cancer screening initiatives here in Texas. I think this, oh yeah. And I'll introduce our speakers in a little bit, but first I'm going to talk a little bit about CPRIT. So CPRIT was created by the Texas state legislators in 2007. The Texas voters voted for CPRIT, and then again they voted again to keep CPRIT in 2019. So we're a $6 billion initiative focused on cancer research and prevention here in the state of Texas. We're the largest cancer research or state-based cancer research investment in the history of the U.S. and the second largest initiative for cancer research and prevention in the world. We have our prevention program, which I'm a part of, focuses on delivering program or services to Texans. To Texans. We focus on uninsured and underinsured individuals. We focus on those that are disproportionately affected by cancer mortality incidents and risk factors. We also focus on certain geographic areas throughout the state that are disproportionately affected by cancer. We fund evidence-based interventions for organizations across the state. And we focus on populations with obstacles to cancer prevention, detection, and diagnostic treatment. We have goals that focus on prevent and reducing the cancer risk and mediating effects. We serve populations in the greatest need, and we work on building capacity to promote interventions and innovations and best practices across Texas. To date, our prevention program has awarded 291 awards, which is totaled just under $355 million. And our grantees have provided 9.3 million services to Texans. Looking at the state as a whole, as of just recently, from September 2023, we have 68 active projects, and I'm happy to say that our projects are represented in every county here in Texas. So if you're trying to count those little boxes, that's 254 counties, which is quite a bit, but we're very proud of that. And you can see our screening outcomes since FY 2010 of who we were able to help and how we were able to help them. Looking a little bit more closely at our prevention base, or excuse me, at our colorectal cancer base projects, we have 14 active projects throughout the state. We almost are represented in every county. I think all but 8, but we'll get there. And you can see kind of where the heavy focus is. Year to date, our colorectal cancer based projects have provided over 700,000 screenings. We've detected over 1,300 cancers, and one of our probably most underrated number, but it's still an impactful number. We have provided services to people that have not been screened before, and that's over 166,000. Over 166,000. And last, I'll just mention one of the newest initiatives that we've taken part of, funded or started by and championed by our Prevention Advisory Council, or our PAC. This year, the legislator approved a rider to House Bill 1 establishing a pilot program to fund colorectal cancer treatment for uninsured and underinsured Texans. So this pilot program will look at those that are diagnosed with cancer and that are at 200% or below of the federal poverty level. But it's a program that was worked on very hardly through our PAC and other champions of CPRIT to get treatment dollar funds for those that are diagnosed with cancer. So without further ado, I will introduce our panel who has done tremendous work throughout the state, and I'm excited to hear more about them. I'll introduce them all, and then I'll let them come up one by one. So first we have Dr. María Fernández. She's the Vice President of Population Health and Implementation Science at the University of Texas Health Science Center at Houston. She's also the founding co-director and the UT Health Houston Institute for Implementation Science. Then we'll hear from Dr. Jennifer Molokwu, who is the Vice Chair of Research and Director of Cancer Prevention and Control at the Departments of Family and Community Medicine and Molecular and Translational Medicine at Texas Tech University Health Science Center at El Paso. Then we'll hear from Dr. Scott Larson, who's the Site Director in Quality and Fellowship Program at the Michael E. DeBakey VA Medical Center, Assistant Professor and Clinical Educator at the Baylor College of Medicine. And lastly, from Dr. Kiran Shokar, who's the Associate Dean of Community Affairs, Chair of the Department of Population Health, Co-Program Leader of Cancer Prevention and Control at the Livestrong Cancer Institute, the University of Texas at Austin Dell Medical Center. So please help me welcome Dr. María Fernández to the stage.
Hello, everyone. Welcome to Houston. And for those of you who are from out of state, in the words of Lyle Lovett, you ain't from Texas, but Texas wants you anyway. I'm going to talk about implementation science, and Emily invited us to say our why. My why is partly because I'm a population scientist dedicated to improving health equity, but my personal why is because I lost my very best friend that I had since 6 years old to colorectal cancer about 1.5 years ago. So this is for her, Debbie Wells Wallace. Implementation science is a tool that we can use to try to answer questions about why do things that we know, why aren't they used in the real world? So I like this quote from Khalil Gibran that says, "A little knowledge that acts is worth infinitely more than much knowledge that is idle." And unfortunately, we have much knowledge that is idle, and we have to ask ourselves, why is this happening? What are the barriers to implementing evidence-based approaches, and what can we do to accelerate and improve that process? So implementation science is actually the study of methods to promote adoption and integration of evidence-based practices, innovations, even policies into routine care. And it really continues the job of clinical and public health research in bringing these innovations into practice. There are a lot of resources for implementation science. There's a great conference coming up in December. There's books, textbooks, there are journal articles. So I encourage you to look into this if this sounds like a science that can help answer some of the things that you're struggling with. And how can it help? Well, one is identifying those factors that get in the way of adopting and implementing and also maintaining evidence-based approaches. It can also help in adapting interventions. We are working in different communities. Not everything works the same or the same way for different groups. It can help plan and implement approaches to accelerate and improve the use of evidence. And it can help stop doing things that don't actually work, what we call de-implementation. And then finally, it can help with the dissemination or the scale up and spread of effective practices. Community and stakeholder engagement, like in many fields, is critical in implementation science. And the view of this kind of engagement is a little broader in that we don't just mean patients, but we also mean those individuals like practitioners, like community health center leaders, like others that are leading and making decisions in community organizations, as part of those key players that are going to be informing and helping us understand what the factors are that influence implementation and what can accelerate and improve it. So implementation strategies, as I said, are these methods or techniques that enhance this process of getting things adopted, implemented, and maintained. And there are a number of different types of strategies, and I liked this layout that Amy Kilburn talked about. And we can think of them as those strategies that push treatments or innovations into use and strategies that pull from the local level to drive practice. And some have suggested that these transformational focus strategies, the ones that actually pull from the local level, are the ones that are more likely to be maintained over time. And these are things that empower individuals, and think, individuals within a clinical setting, for example, to think strategically and have ownership in delivering treatments. So there's a lot that we need to do to plan implementation strategies and test them. And one way that we have done this in our work is using intervention mapping. And intervention mapping is an approach to planning multi-level interventions, and it actually has been used in implementation science in a number of ways. And the first is in planning these interventions in a way that makes them more likely to be used with community engagement, using theory, using evidence. Another is in guiding the adaptation of effective interventions. And then the third is in designing implementation strategies. And there's a new collection of articles that was published in Frontiers in Public Health that highlights how implementation mapping has been used in places around the world. In our project, and this project actually was kicked off with our own Allison Rosen as the leader, the project coordinator. This is a CDC-funded project, and the goal is to improve the use of evidence-based interventions in community health centers. So we are working with community health centers in both urban and rural settings, and as you can see by this chart, very low initial rates, not anywhere near the 80% that we're going after. And the focus was to primarily focus on these ones that are to your left. Patient or client reminders, provider assessment, and feedback strategies in reducing structural barriers. We know that these work. These are recommended by the U.S. Preventive Services Task Force based on systematic reviews. So these are evidence-based approaches, but we also know that many community health centers aren't adopting and using these. And so the focus was to help these community organizations do that. And so when you look at this organizational readiness assessment, you can see things that are typically recommended, assessing whether or not they're currently using, looking at EHR use, et cetera. Another thing that we added was assessing readiness using the readiness inventory, and this stands for readiness equals motivation times two types of capacity: innovation-specific capacity and general capacity. So innovation-specific capacity is, what is the capacity of this organization to do this specific thing, versus general capacity is, what are the supports or organizational functioning? And we assessed this in the clinics, and they got a readiness report that helped us focus on those things that were most keeping them from being able to advance in adoption and implementation. And so these are some of the strategies that came out of the process: practice facilitation, use of Project ECHO, program champions, provider and staff training, and linking with external partners. We know that these have been effective in other settings as well. And so I'll just end by saying that implementation science has really helped us in trying to address those challenges that come up when we're trying to increase the implementation of evidence-based practices in community health centers. And many of these community health centers were experiencing substantial barriers, particularly because of COVID, but also because of all of the other things that they typically struggle with. including limited resources, but identifying those factors that were most important and were most limiting was really important. So using this science can help build an actionable and pragmatic knowledge base that not only helped within our systems, but can help more broadly. And I just want to underscore that last point of engaging stakeholders at all levels was really critical. Stop there. Thank you. Thanks to the collaborators as well.
Okay. So thank you again for inviting me. I'm Jennifer Molokwu from Texas Tech in El Paso. I realize that many in this room may not know where El Paso is, and just for context, it is in the far west of Texas, as far west as you can go in Texas and still be in the state of Texas. It is a community that boasts 825,000 people who live there, 87% of whom are Hispanic in origin. If you add the fact that we border Mexico, Juarez, Mexico, and we also border the state of New Mexico, El Paso drives for healthcare, culture, and just livelihood, a population closer to 2 million in activity. If you think about our sister city, Juarez in Mexico, and people who come from New Mexico for healthcare, for family visits, for culture. Because of that and our healthcare needs, we have unique challenges and problems. One, cultural. Two, access. We have high poverty rates. And we started with trying to understand the health disparities and concerns that are within our locality. My talk today will describe a little bit of how implementation science works in the real world practice. This slide, we know that colorectal cancer is much better treated. The odds of survival are better if it's diagnosed early. And we know that we have fairly high incidence of colorectal cancer in Hispanic males, especially in our community, with higher than average mortality rates. Some of the reason for that is that our screening rates are lower than the state average, but also lower than the national average. And so we set about to understand why this was the case. And in developing our colorectal cancer screening program, which we will talk about in a few seconds here, we had focus groups, community interactions, and a lot of the barriers that we found were, one, there was some structural barriers that just access. We have about 25% uninsured rate, but there were also cultural barriers like fear and embarrassment. You know, there's the machismo culture and male Hispanics, which makes it uncomfortable to have discussions about colorectal cancer, the unpleasantness of the test, physician recommendation, and the fact that, you know, they don't feel sick and so have no need or understanding of the need to get colorectal cancer screening. And so in 2001, based on the foresight and planning by Dr. Navkiran and Shokar, who you will hear from in a few minutes, our Axion program was initially developed with funding from CPRIT. And what we did was developed a theory-based, culturally tailored, bilingual, evidence-based screening program. So we took the information that we got from our focus groups about what the barriers to screening was in our population. We took information from our community members about what was important to them when planning a screening program, and we integrated that with best practices and evidence bases to plan a screening intervention program with CPRIT funds. We made sure that our community was involved in every stage of the planning. We looked at a very important component for us in the community base was the use of community health extension workers. We found that it was important for people to be able to discuss with people who look like them, talk like them, who they perceived as members of the community. So we used trusted members of the community who were educated about barriers, causes, risk factors for colorectal cancer, and we actually went to meet patients where they were. Because when we think about a lot of barriers, insurance is one, but even with people who are insured, who have to work multiple jobs to make ends meet with our high poverty rate, many times people don't have time to go to the doctor. And so our outreach workers went to health fairs, community centers, churches, school groups, and provided the education and outreach there. We had patient navigators who helped our patients and participants navigate through processes of testing, submission of testing results, follow-up testing, and all of that. We use earned media, invitation to talk to get the word out to communities. We use our collaboration with a lot of community organizations. We had over 200 community organizations who collaborated with us in this endeavor, inviting us to community programs, letting us know when they were doing things, reaching out to us if they had any issues or concerns. And with the funding that we received from CPRIT, we're able to provide screening and diagnostic tests for our community. Our primary screening method was stool-based testing, but for people who are high risk for colorectal cancer, we did offer them primary colonoscopy as screening. And of course, we're able to pay for follow-up diagnostic testing for the people who did test positive for colorectal cancer. Since the inception of our program, we have enrolled over 3,500 individuals, 40,000 fits. This was as of September, but so over 40,000 fits have been given. You can see the numbers on colonoscopies and diagnostic colonoscopies and 33 cancers. But what is important to us is that in our cohort, our screening completion rate is at 72.8%. And now if you remember in the initial number, because this is a largely Hispanic population, the screening completion rate for colorectal cancer for Hispanics in our community was at 54%. And so we're not there at our 80% in every community, but I think that we are getting darn close to getting there. So this is our group of community outreach workers who are the heart of the work that we do. And so thank you for your time.
Good afternoon. I'd like to thank the organizers for inviting me, and I am just filled with gratitude being here this afternoon. As I get into my talk about identifying current clinical care processes to reduce delays in colorectal cancer diagnosis, really the focus is the solutions to these things. My whole career has been in underserved populations that are FIT or FOBT first and screening. And so getting into it, this is me, Scott Larson. I'm at the DeBakey VA Medical Center right here in Houston. When I started, we underwent a formative process, mapping out the process from, on the left, that blue, FIT positive. That's a colonoscopy that is ordered with the intent to follow up on FIT positive colon cancer screening. On the far right, the green, that's a completed colonoscopy. As you go from left to right, each diamond represents where that initial colonoscopy order, it falls out. It gets canceled for some reason. We've focused in on some provider-related barriers. We're going to talk about one of those specifically. We've also looked at some patient-related barriers. In that process map, there are GI doctors, primary care doctors, GI nurses, schedulers. I would say there's 10 plus hands at each of these touch points trying to get a FIT positive colonoscopy order to a completed colonoscopy. And the one thing that is missing here is a dedicated patient navigator that can be there from the time someone becomes FIT positive until they get that colonoscopy done. Going into, here's one of the interventions we did at the provider level. When you order a diagnostic colonoscopy for a FIT positive indication, it needs to say so. And the initial order set for the diagnostic colonoscopy, a positive FIT, wasn't an option. And the provider would have to kind of intuitively know to check other and then type in positive FIT. If that didn't happen, the colonoscopy order would get canceled or they'd be asked to put in another one. So we updated the EMR and added positive FIT to it and did some outreach with our providers. And now, approaching 90% of these colonoscopies get ordered correctly right up front. Going to some patient-related barriers, when patients come in and they had to be canceled for different reasons. Part of it we found out was our prep instructions. And here's one of the iterations we had that was a 2-page Word document with bold, underlined, different fonts, different font types, highlighting, and then a lot of areas that says don't do this. And so it's full of do's and don'ts. And so, but what we did is we met with our ordering providers and we met with our patients and said, what works here and how could we do better? And they helped us to design a new tri-fold packet for preparing for your colonoscopy. And one thing I'm pointing out here is the QR code that got added, and that's a direct link to our website that has all this information, and soon to come on the website is a video that will walk patients through on actually how to mix up the prep and get through it. On the back side of it, we've got it streamlined to frequently asked questions, their timeline. One thing that we've added to this timeline now is for them to ask their primary care providers about their diabetes and weight loss medications, because the GLP-1s are going to be a barrier for cancellations now. And then a stool chart with some actual colors of what their effluent should look like. Another thing that was a barrier was we asked pre-op questions. We're trying to predict if someone's going to have a bad prep. And we did a retrospective study of almost 300 patients and found that 9% of patients were being canceled or rescheduled for presumed inadequate bowel prep. Of these, 70% did get rescheduled, but 4 months after their cancellation date, and these patients have already waited 6 months. And these are FIT positive patients. Even more eye-opening is that 30% of them, a year later, they've not had their colonoscopy done. And this is consistent with the literature that shows 25 to over 50% of patients that show up for a colonoscopy that have tried the prep, they don't come back at all. So one of the interventions that I brought to the GI lab was a rescue device that's over the scope irrigation system. And I went to the GI lab and I said, send all these presumed inadequate bowel preps to my room and let's see what we can do. But early on, I found these patients were clear. They didn't need much cleaning at all. And so we still have this. It's actually rarely needed. And we changed our algorithm. And so now, we ask them about their stool and about how much prep they completed. But if they ate, we're much more lenient. And if they ate a little breakfast, and they go to any endoscopy room. And if they ate later, we send them to a rescue device room. And this has decreased our same-day cancellations for presumed inadequate bowel prep to less than 3%. Another thing we're doing is we have a spinal cord injury unit in the VA. And these patients, they get admitted to the hospital for elective endoscopies. And their bowel prep is a 3-day bowel prep, 12 liters of Go Lightly, magnesium citrate, almost daily if we have it in stock, a daily enema, and then optional Foley catheter and optional rectal tube. More than half of them, the day of their scheduled colonoscopy, wind up not being ready. And they need an additional day in the hospital, more prep, or just rescheduled. And in the conditions I have listed there, these patients have used pulsed irrigation evacuation for chronic constipation and fecal impactions for decades. They've used this pulsed irrigation device, or pulsed irrigation evacuation. And we are bringing it in to pilot in our spinal cord unit, and here's what it looks like. It's a standalone unit that it actually will pulse irrigate tap water at body temperature and has its independent collection system there. And our hopes here in this population is that we can give them a better PrEP experience, and then also they can get a timely and high quality colonoscopy like all of our patients deserve. I'd like to thank the people that have collaborated with me on these endeavors, and again, thank you for letting me speak this afternoon.
Good afternoon, everyone. Okay, so this is me. I'm Kiran Shokar. I've been in Texas for 27 years and a very proud Texas implant. I would like to also welcome you. I'm the chair of the Department of Population Health at Dell Medical School, also the Associate Dean for Community Affairs and the Program Lead for Cancer Prevention and Control. And I've spent my whole career focused on health disparities in cancer screening and in particularly colorectal cancer. So I'm really happy to come here today to speak to you about where we are. So these are the things that I'm going to address. I'm going to talk about where we are in Texas with colorectal cancer screening, where we'd like to go, and how we're going to get there. So here's a lot of numbers, but I think it helps to set the scene. So Texas has a population of over 30 million. We have one of the highest rates of lack of insurance in the US. We're at 16.6%, so that means 5.2 million folks do not have insurance. We're a majority minority state, and we also have a vast expanse of Texas is comprised of rural counties with a few urban centers spread throughout the state, mostly in the central part and the eastern part of the state. We're a non-Medicaid expansion state, and that has implications for how we do this work. And if you look at the numbers, there are about 10 million age-eligible Texans for colorectal cancer screening, and about 1.1 million of those in that age group 45 to 64 are uninsured. So that's the scope of the problem. We're very fortunate to have CPRIT in this state, in Carlton. Thank you for educating everyone a little bit about CPRIT. CPRIT on the prevention side has about $30 million a year set aside for prevention program funding, where they actually fund services. So that is the best news we ever received in 2011, those of us working in this field, and really committed to health equity and health disparities. So that's across all screening preventable cancers. CPRIT's priority populations are those that are underserved, uninsured, and don't have access to care. So we have this remarkable resource that we have experience with now for over a decade, and we're fortunate enough to have that resource for another decade. So as far as colorectal cancer goes, currently there are about 15 grantees. I think 2 grantees merged, so there's now 14. And they provide about 70,000 screening tests a year. So if you look at the difference between the 1.1 million uninsured that we're trying to intervene on and what the CPRIT program with some portion of the 30 million is addressing, there's a big shortfall and a big gap that we need to address if we want to get anywhere close to where we need to be with colorectal cancer screening. So we do have a lot of experience in this last decade of work in the program grantees and the way they've implemented their programs across the state. And you can see, I don't know how well you can see, but there's some red stars on there which shows the grantees, primarily the academic health centers. There's one community organization and one safety net hospital system, but these programs originate in academic health centers, and there's a lot of reasons for that we can go into. So where are we with colorectal cancer screening? Well, I put some figures up there which show the kind of trajectory over the last decade. And you can see that Texas started off at lower rates than the US average, but we increased by a higher than average percentage, 8.3 over a decade, whereas the US average was 7. And the UDS measure is the measure that community health centers report. They report their colorectal cancer screening rate. So the 72 federally qualified health centers in Texas, and their average at the moment is 34. They started around 30. It increased up to about 38 just before the pandemic, and then unfortunately the rates fell off. So we have a lot of work to do. They see about 500,000 patients in Texas that are uninsured. So about half of the folks that are uninsured that need screening are in these federally qualified health centers. So it's important to keep that in mind. So yeah, so we have a lot of work to do. We're not close to 80 yet, and we hope to get there very soon. So if you look at the graph, you can see the red arrow shows where Texas is, and it looks like we're near the top, but the top is actually where you don't want to be. The higher screening rates are at the bottom, so we're in the lower quartile, quintile, and we'd like to be much higher in that. So how do we get there? So this slide shows some of the things that I think, based on the experience, collective experience of grantees, to work that's happened in other states, there's a lot we've learned about what we need to do. So one of the things is that it's clear that if we're going to impact health inequities, we're going to have to access patients and individuals in the healthcare system. That's obvious. That's where most screening happens, right? But we need to be more creative in how we do that. So I'll talk a little bit more about that. Traditionally, we've used visit-based approaches. If the patient shows up and the provider remembers about colorectal cancer screening, because the provider already has about 6 or 7 other things they have to do for the patient before they get to prevention, right? So that's what we relied on. So with data, we have the opportunity to really use population medicine-based approaches where providers are looking at their whole panel and identifying people that might be eligible and reaching out to them. So that's something we need to do. But we also need to look at community pathways to reach people that are not in the healthcare system. And so this project that we described, that Dr. Molokwu described earlier in El Paso, that started off as an entirely community-based program that reached individuals that were not in the healthcare system, developed a care pathway, connected them to care. And so that was really important in that community with very high rates of uninsurance and lack of coverage with a lack of having a healthcare provider. So if we're really going to move the needle on colorectal cancer in Texas, we're going to have to use both of those approaches. Then we know that multi-component interventions work much better than uni-component, and that we have to work at multiple levels, because what we learn is that the barriers for colorectal cancer screening are across all levels, from the individual to the interpersonal factors to organizational barriers, community-based barriers, and then policy as well. So, and the more components you have addressing each of those, the more effective your interventions are, but they're also more costly, so there's a balance equation there. And then we also know what works well in the effective programs, and there's a lot of data from other state-based programs and other programs throughout the US that were, there was a seminal article a few years ago, Dr. Wender was part of producing that, where they evaluated program features of successful state-based programs. And so these were some of the things that came up. You know, they're obvious, right? You have to have high-level champions, people that are passionate, just like we all are in this room. We need to use data-driven approaches. We need to have learning systems, adaptive designs, so that we can respond and make course corrections to kind of keep achieving the goals that we want to keep. So those features are really important to include in interventions. So I'm going to talk now about the future. So CPRIT recognized that in order to scale screening and get to the next level to propel colorectal cancer screening across the state, that we needed to get more, we needed a specific focus on that. And they created this RFA to kind of help to get some thinking around how we scale what we've done, what we've learned, what's known, to a state level. these programs that I described, they're all very independent. They have their own regional networks, and they're doing great work. But clearly, we don't have the reach that we need to get to where we want to with colorectal cancer screening. So we need to have more strategic efforts to leverage the gains that have been made. So this proposal, Coordinating Center for Colorectal Cancer Screening across Texas, was just funded. And the nickname for it is Connect. And fundamental to this is what you see at the bottom, which is the stakeholder network. So it's really critical that we include all people that are involved in the colorectal cancer screening pathway, from patients all the way up to health systems, to come to the table to think through how we do this. There's a lot we know, and we've organized this center around 5 cores that focus on really critical elements that need to be part of a state-based strategy to get us to the next level with colorectal cancer screening. So I'm going to talk in a little bit more detail on these. So our overall approach is that we want to galvanize screening efforts across Texas, that we want to come up with a comprehensive state-based strategy. We want to develop the plan. We want to develop the resources and infrastructure to support the plan, and then we want to start operationalizing it. And what we need to do is to scale these evidence-based strategies that we already know work, just like Dr. Fernández and others mentioned. How do we scale those, and how do we incorporate them into a strategy that's across the state? So you already heard we have 254 counties. We have 30 million population. You can drive for a day and night and go from one end of Texas to the other. The scale is just phenomenal. If you fit Texas over Europe, most of Central Europe would fit inside Texas. So, you know, it's a big undertaking. So it's important that we collaborate, partnerships, trust. We capitalize on these regional networks that have already been developed. And we're going to have to adopt a hub and spoke approach where there's a centralized resources and infrastructure, but the purpose of that is to support dissemination through the regional networks and other stakeholders across the state. And we serve as a source of support, expertise, and resources. And then, you know, we're going to have to think about our care pathways. We need colonoscopy access across all the counties. It's not there right now. We need lab access. We need, oncology access. That's not consistent across the state. So these are big thorny problems, but we're going to think about those, figure out how we can leverage the work that's happened regionally where these kinds of activities have happened, and how we can scale that to areas where they're not as developed. And then, of course, we have to tailor to populations and barriers that are specific in different regions of Texas. They're very geographically different, but they're also, the population composition is also different too. And then we have to integrate across community approaches, public health approaches, clinical approaches. We need to target individuals, patients, providers, practices, because those are the things we know work. And then finally, in order to make this sustainable, we're going to have to support advocacy efforts to support funding things that we know work. So that's kind of the overall plan for the next 5 years. I think we're going to be quite busy. I'll just briefly touch on this. I'm not sure how we're doing for time, but this core is about community-based program development. It's providing implementation support and resources and expertise in community-based research methods so that people get the support that they need in the areas of the state they are to really learn about their communities and what aspects of the program need to be tailored or developed in a specific way. We also are going to create a repository of resources that are already available through NCCRT, some of the programs and some of the work people have been doing across the US. So we're going to gather those materials, try to organize them, and annotate them to help people that are planning to incorporate interventions to identify the ones that are most relevant for them. And then, we're going to be there to provide resources. We heard about navigation. navigation is really important. And the program we have in West Texas was effective because we had a very specified protocol for navigation. We reduced as many of the structural barriers as we could. The navigators made the appointments. The community health worker was also another very important component of successful community-based interventions, because they were able to provide the information that was needed. They taught people how to do the FIT test, the home stool blood test. They taught people about the PrEP, and we actually provided the PrEP to them, so they didn't even have to go to a pharmacy to do it. And we had reminders, all the appointments were made for them, and that's why the completion rate is so high, because we try to fix all the gaps that the doctor here was talking about from the VA, so that they had as seamless a journey as possible. So these are some of the things the community core is going to do. And then the clinical implementation core is really going to focus on the practice-based strategies. So we have on our team for the grant, the Texas Association of Community Health Centers, which represents the 72 FQHC systems across Texas. So we're going to work with them to identify practices that would be willing, have good alignment, and will be interested in implementation support strategies to help them to integrate evidence-based practices into their care. So that's one component of that. Stakeholder engagement, of course, throughout the process. And then, with regard to scaling, we're going to explore the idea of developing a centralized FIT mailing program, FIT mailing capability across the state, so to make it easier for smaller organizations and others to be able to send their FIT test to that. And there's the opportunity for scaling and automation, and that could really decrease the cost. And then we're working with the Texas Society for GI Endoscopy to look at this colonoscopy network. How do we create that in urban and rural areas of Texas to create the infrastructure so that if people, whatever county someone is in, our vision is that every person in each of the 254 counties would be able to identify exactly where they go for screening and where they would go for colonoscopy, and that we would have a navigation network to help support them in accessing those appointments. And the same for oncology. There's a lot of access difficulties with oncology, especially for uninsured patients and especially in rural areas. And then, we hope that we'll be able to support some organizations to apply for CPRIT funding of their own. This core is about modeling, mapping, and cost effectiveness. This is using modeling techniques to identify priority areas of the state which are low-hanging fruit simply because of the numbers of people that would be eligible for screening and access that already exists for colonoscopy and mailed FIT access. And then another component is creating information about modeling and cost effectiveness to inform people that are trying to implement these programs, and also payers, about what are the trade-offs in reducing cost versus adding different components. What would be the cost implications? What implications would it have on outcomes? So that's also for policymakers as well. And then we propose to create a dashboard to help to communicate this to folks. And then the data strategy for tracking, and I won't talk too much more about that. And then the advocacy core, you already heard about the Prevention Advisory Committee supporting these efforts to get the legislature to set aside funds for colorectal cancer treatment screening, treatment costs for poor folks in Texas. So that's $10 million. It's not a lot, but it's a start, and this is a really major achievement because we hope to build on that. But we also need advocacy around, navigation and community health workers and those kinds of things. So this is what we're going to be doing over the next 5 years. I think we'll be quite busy, but if you don't think big, you won't get close, right? Thank you.